We all have hormones. And if you've made it this far in life and you're basically an adult, you've probably noticed that hormones can drive us a little crazy now and then. I mean, hormones control our temperature, hormones control our sleep, hormones control our mood, our stress. Hormones even control the way we grow. Dr. Munier Nour studies hormones in children, what makes us grow and what makes our bones strong or brittle. He's our guest today on Researchers Under the Scope. Hey, I'm your host, Jen Cannell, and this is the last time we're putting a researcher under the scope in 2023. We're online today with Dr. Munier Nour. He's a pediatric endocrinologist and a clinician here in Saskatoon. He's an associate professor with the University of Saskatchewan's College of Medicine, specializing in pediatric endocrinology and diabetes. Welcome to Researchers Under the Scope, Munier.
Thanks, Jen. It's a pleasure to join today.
Okay, and when I think of pediatric endocrinology, I'm thinking about hormones, cortisol levels. I'm not thinking bones.
Well, it's actually kind of interesting. A lot of people don't realize, but your bone is actually the largest endocrine organ in your body. Produces a couple different hormones, and it certainly responds to a number of hormones as well that are produced. And so I think it's certainly under-recognized that it is an endocrine organ.
How are they endocrine organs? Like, they seem all hard and not soft like the way my other glands are.
Yeah, so bone is actually quite dynamic, and there's living cells within your bone, and those cells respond to various stimuli and signals from the body. Some hormones that are produced by bone include things like FGF23, which has a lot to do with our phosphate metabolism. As well, there's another hormone called osteocalcin, which actually has quite a role in diabetes as well. Some of these hormones are fairly newly recognized, and certainly a lot of understanding is still required for a lot of those hormones.
So going back in time, at what point did you start to get interested in science and possibly in studying hormones, just in being a doctor in general?
So I think I always wanted to be a doctor. When I finished high school, I went into engineering and sort of as a backup
Wait,
plan.
okay. So I wanted to be a doctor, so I went and got my engineering ring, or
Yeah, so I think I've always had a fairly logical approach to things, and I think engineering really was quite a logical specialty or profession, and so it certainly appealed to the way that my mind works. And I think out of high school, people are give recommendations that you should always have a good backup plan if you wanted to go into medicine, and so I think I had a bit of a career trajectory of wanting to go into biomedical engineering as that backup. And so if things didn't pan out for medicine, then that's where I would have found myself.
cool. So at what point through your engineering degree did you think, I'm going to apply for medicine?
Early on, so I got into medicine prior to finishing my engineering degree. So it was about 3 years in, and then I transferred over to the med school program.
And then from there, where did your career kind of take you, just in terms of veering more towards pediatrics for starters and then endocrinology?
Yeah, so I think the medicine aspect of medical school appealed to me. So I saw myself either going into kind of internal medicine or pediatrics. But certainly I think working with kids, I think introduces new challenges and a lot of fun in kind of the day-to-day work. Certainly there's extra challenges sometimes working with children and their families, but overall, I think there's a bit of an innocence to pediatrics, and as well, I think it smells better often in the hospital compared to adult medicine. So I was certainly drawn to pediatrics above internal medicine.
It smelled better. um, so as you're going through, though, would you say there were any people or moments that really made you know that, yes, this is where I want to be? Or
Yeah, so I think originally in my pediatrics training, I was planning on going into pediatric intensive care. Again, it's a fairly logical specialty, and a lot of A causes B, therefore C. And then supposed to do a endocrine selective, but just in my home program, but unfortunately that was canceled. And so I set up an elective sort of accidentally with the group in Calgary, and worked with just a wonderful pediatric endocrinologist, Dr. David Staffier, who's since retired, but he was one of the main endocrinologists that kind of built the program there. And he was just a wonderful mentor and really kind of sparked quite an interest and passion to pursue pediatric endocrine after just that one month elective. It certainly wasn't on my radar at all, but after working with him and the group there, yeah, fairly quickly changed a lot of my career plans, and very happy that I did.
What was it about that month? Like, what do you actually remember about it?
I think looking at kind of how my brain works, I want again kind of that logical approach to things. And I think dealing with hormones, there's a lot of feedback loops and a lot of kind of A causes B, therefore C type thing. And as well, I think the work-life balance of the specialty made a bit more sense for me as well.
Yeah, pediatric ICU, there, I don't imagine you'd get a lot of work-life balance.
Exactly. Yeah.
So at what point did you move to Saskatchewan?
Yeah. So I came to Saskatchewan after completing my fellowship in Calgary. I also completed a master's in biomedical sciences, looking at bone health in a particular group when I did my master's there. And so when I came to Saskatchewan, I came taking over as the sole pediatric endocrinologist for the province. And so certainly it was fairly busy time, and I think not a great deal of time to do things like research, but
No, you would have
certainly
been
wanted
swamped. Sheesh.
yeah, it was maybe a dark time. But yeah, with that, certainly wanted to gradually build a bit of a research portfolio, and thankfully there's some phenomenal people here in Saskatchewan that I was able to work alongside with. So I think one of the main people in the College of Kinesiology is Dr. Saya Conchalainen, and very early on we met and started to discuss potential research opportunities.
Okay, and now you're not the only pediatric endocrinologist anymore.
No, thankfully we've since hired two more wonderful colleagues here yet.
And that does allow you to kind of look at things in the bigger picture. And what's the main question you're trying to explore and answer?
So I think it's been recognized for quite some time. Actually, I think it's been over 100 years that patients and children with type 1 diabetes have differences in their bone development that put them at risk for fracture and osteoporosis, both as children and into adulthood, and that risk probably increases even further as adults. There's been some recent studies that have shown that risk of fracture increases by like 15 to 35% in childhood, and then into adulthood, it's probably a 3 to 6 fold increase in the fracture risk.
Just for having type 1 diabetes.
Exactly, yeah. And I think with that, there's been a lot of kind of, I guess, surprise that patients with type 1 diabetes have that much of an increased risk. When we look at a comparison of patients with type 2 diabetes who have, I think, many more potential insults to their bone health and metabolic dysregulation. However, their risk of fracture and osteoporosis is nowhere near as high as those with type 1 diabetes.
Ah, so you're trying to figure out what's going on.
Exactly. So the whole goal of our research is to assess kind of what some of the differences are in bone development and bone microarchitecture development in children and adolescents with type 1 diabetes. And I think our main hypothesis is that because type 1 diabetes occurs so early in life, and it occurs before kind of key crucial bone development, that it influences that bone development that occurs during your peak growth in your adolescent years. And so if there's some sort of a detriment that occurs during that development, then it impacts the bone health for the rest of your life. There's a lot of, I think, misconception that osteoporosis is an adult disease.
Yeah, because
really
it's my grandma all hunched over. I only see it in old people.
Exactly. However, I think as pediatricians, we sort of view that osteoporosis may actually have its origins during pediatric years. And so all of your bone development and growth and bone strengthening happens during your adolescent and early adult years. And so it's almost like you put all of your bone into the bone bank during your childhood and adolescence. And then after you're done growth, you continually make withdrawals for the rest of your life. And so if that key bone development doesn't occur properly during childhood years, it may influence you as an adult.
You end up with a bone bank account that's way lower than all your peers who didn't have type 1 diabetes.
Exactly.
So, what does your research itself look like?
So our research is longitudinal research, and we're looking at adolescents kind of right prior to and through those key years of peak growth. And so we're recruiting boys and girls generally kind of between the ages of 10 and 12, and we're following them with annual bone health assessments. And so there's various tools that we will be using for those bone health assessments, including imaging and things like that. And we'll be following them on an annual basis to see if there's differences compared to their typically developing peers.
How many boys and girls are you trying to recruit?
So in total, it's between 200 and 210 is the goal. And so with that, we'll be recruiting both here in Saskatchewan and several other centers across Canada.
Are there any grants that are making this possible, or is there anything that we should mention that has really made this a reality for you?
Yeah, so just this past year, our team successfully applied for and was granted a CHR grant to extend this research across the country. So we had begun doing the research here over the last few years, just with a Saskatchewan group of patients with type 1 diabetes. But with this grant now, we've expanded and we're leading a national initiative, and we've expanded to a few key sites in Canada. So there's a site in Ottawa, in Toronto, and in Calgary, and then our group here. And with that, we're just in the midst of launching that national initiative for some really exciting research and work here.
So when a boy or a girl comes in to visit with your research team, it's, you said, once a year, like an annual check. What'll happen for them?
Yeah, so there's several different measures that will be completed. I think one of the main tools that we're using is something called HRPQCT, or High Resolution Peripheral Quantitative CT, which is certainly a mouthful, but what that is basically a high resolution image that we take of bone at a peripheral site. And so we do scans at the wrist and just above the ankle, so radius and the tibia. And with that, we're looking at different aspects of the bone there. So we get a 3D image of the bone, and so we can look at the bone microarchitecture, separate things out by the cortex, which is the outer layer, and the trabecula, which is kind of the inside sort of spongy lattice work. And you can measure many different things there. So that the density, the number of trabeculae, the architecture, and as well there's even fairly advanced engineering techniques that can be used to kind of simulate a fracture load and see when that bone would actually fail without having to expose that bone to that force.
Yeah, without having to say, okay, come here, kid. Like, you can't,
Yeah,
no.
we're going to see what it takes to break your bone.
Yeah.
Exactly.
Well, but theoretically, if we were to break your bone, it would take this much force. You can actually tell that.
Yeah, exactly.
Which is cool.
And so that's the main tool that we'll be using to look at how bone microarchitectural development is different in those with type 1 diabetes versus others. There are certainly a number of other tests that will be performed. So things like muscle strength testing and using things like force plates and assessing jumping and whatnot. We'll be doing some of the other standard measurements as well, of bone density, and looking at as well some of the hormonal influences. So things like measuring IGF-1, which is a measure of the function of growth hormone, and as well as some of the markers of bone turnover, so markers of bone deposition and resorption, to see if there's differences there.
And so in the big picture, What do you think you're going to start seeing in these scans, especially over time?
I think broadly we would expect that there is some sort of inferior bone development in those with type 1 diabetes. And so whether that involves the trabeculae or kind of the microarchitecture, I think it still remains to be determined. Certainly some of the early results that we're seeing is that it may more so influence the bone trabeculae. However, this is ongoing, and I think seeing how things develop over time. So far, most of our data has been cross-sectional, and really to best understand it, we want to see how this develops over time longitudinally, and how it differs from those children without diabetes.
How long will they be taking part in the study, ideally?
So it would involve 3 visits, so kind of over 2 years. So at baseline, year one, and then year two, and yeah, hopefully we'll have patients that are prior to their peak growth, and then catch them over those peak growing years.
And after about age 14, 15, do your patients still keep growing or not enough to bother tracking it at that point?
It's a great question. Currently, we're funded to do over the 3 visits there, but certainly I think one of the things that we are keeping in mind is that there's a consolidation of growth or a consolidation of bone density that happens even after you're done growing. And so certainly we would love to continue to assess past that. And I think as this study is underway and as we kind of expand across the country and collect data, the hope would be to continue to do this research, because I think it is going to be quite informative and important to continue to assess even beyond those years.
Well, I mean, if I could jump, say, 3 or 4 decades into the future and somehow another grant came through and we did manage to track these kids, does that mean that if you could figure out what some of the factors are, like how these bones are not developing the same way as their peers, would you be able to treat that or intervene?
Yeah, so ultimately the whole goal here is to try and change the trajectory for these patients. I think so little is understood right now about kind of what is different and why, and so I think this research will help inform some of those questions. Ultimately, the hope is that we can then use that knowledge to build into what can we do to prevent. And so there's different possibilities there. We certainly will be looking at kind of the patient's activity levels. We'll be looking at nutritional factors. We'll also be looking at their diabetes management and control and their growth during those years. So there's various factors that can certainly be at play. And so knowing how to intervene will depend on what we find with the study.
Well, and it all kind of does have layers, but I keep thinking about how you have that engineering brain and like a very sort of methodical, like this is what I'm looking for, and sort of a sequential brain. That's gotta help in cases like this, especially when you're going through so many different layers, like of a longitudinal study.
Yeah, and we've got some great help as well for all of the logistics there.
That is awesome. Any last thoughts just in terms of like the patients that you're seeing now? This might not make a difference for right away, but yeah, what's sort of your hope with this?
Well, I think I've got to say I've certainly been very appreciative to the patients and participants in the study. We've also partnered with Diabetes Canada with our diabetes camp, and so a big place where a lot of the recruitment and as well as some of the knowledge translation and some of the patient advisory comes into it is at our diabetes camp, and so we have a lot of fun at our camp every year, and we've been able to use that as a place to also recruit and engage with the participants.
Wow. And you balance all this with clinical rotations. Like it's not a big deal at all. That's a big deal.
So yeah, but certainly I think this is really enjoyable research, and I think it's research that needs to be done, and it's exciting to see it be fruitful here.
For sure. And it was lovely to meet you. I hope I never see you in the hospital. No offense, but
That's fair.
okay.
Yep, it's mutual. So
Okay. Take care.
great. Thanks, Jen.
Bye-bye.
Bye.
Dr. Munier Nour is a pediatric endocrinologist and an associate professor and biomedical researcher at the University of Saskatchewan's College of Medicine. As you heard, he recently won support from the Canadian Institutes of Health Research. That grant will help expand the longitudinal cross-Canada study of bone development during key growth years. And it looks at the effect type 1 diabetes has on children during those years. We'll put a link to his research in our show notes, and you can find more at medicine.usask.ca. Researchers Under the Scope is a presentation of the Office of the Vice Dean of Research at the U of S College of Medicine. We produce and record this podcast on Treaty 6 territory, and we pay our respect to the Métis and First Nations ancestors of this place. We reaffirm our relationship with one another, and we'd like to wish you a Happy New Year. Thank you for tuning in. I'm your host, Jen Cannell, and stay in the loop. When we drop new episodes of Researchers Under the Scope, you never quite know who you'll meet here. So find those 3 little dots up in the corner, hit follow show so you can stay up to date.